Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's October 2021 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. This month's Editor's Choice is a special article entitled Physician Wellbeing 2.0, Where Are We and Where Are We Going? It is authored by Dr. Tate Shanafelt from Stanford University in Palo Alto, California. Physician burnout is a tragic and costly phenomenon that profoundly impairs patient care, the delivery of patient care by healthcare centers, and the professional and personal lives of physicians so afflicted. In addition to the personal pain it imposes, the inherent tragedy of this condition is that it leaves afflicted physicians bereft of that laudable, altruistic motivation of promoting healing and health in others, and which, in the first place, led them to undertake the long and challenging training required for a medical career. A pioneering group that has led the way in defining, elucidating, and discerning solutions for physician burnout is that of Shanafelt, West, Derby, and colleagues. Mayo Clinic Proceedings is privileged to publish in its current issue a special article by Shanafelt that comprehensively charts this field, beginning with the initial recognition of this condition, delineating its current state and salient issues, and looking ahead to the continued implementation of strategies and processes that will mitigate burnout and promote physician well-being. Shanafelt identifies 3 phases, designating each with a title that encapsulates the key issue. The first phase is that of the era of distress that reflects the field as it existed up to some 15 years ago. This phase is characterized by a lack of recognition or the deliberate sidestepping of the issue of physician distress, with little scholarship and research addressing this issue. During this phase, there was a pervasive view that if such a condition existed, it was a reflection of the personal weakness of the physician, the latter generally expected to be invulnerable to such stress, the challenges of a burgeoning professional workload, and an increasingly complex healthcare environment. Shanafelt categorizes the second phase as physician well-being 1.0, one that continues to the present day. This phase is characterized by awareness and attention to the problem, scholarship and research to define the drivers and consequences, and early intervention efforts. During this phase, substantive changes in demographic profile of physicians, the training of physicians, and the practice environment occurred. Healthcare systems and their leadership recognized the adverse effects of physician distress on patient care and on their return on investment in delivering patient care. Key insights during this phase were that a culture of wellness should be created and fostered for physicians, and that the primary underpinnings of physician distress reside in the medical practice environment with all its complexity and change, emphasis on relative value units, quality assessment, regulatory and administrative oversight and restrictions, reimbursement issues, and reliance on the electronic health record. Despite this recognition, the solutions devised largely focused on cultivating personal resilience so as to endure a broken system. Over the last 3 to 4 years, leading institutions began to usher in a new phase labeled by Shanafelt Physician Wellbeing 2.0. Broadly considered, this is an effective phase which seeks to introduce system-based and organization-based processes and initiatives, which, in aggregate, would evolve the practice environment to mitigate distress, promote well-being, and cultivate a professional culture of vulnerability and self-compassion. Key characteristics of this phase include initiatives that focus on people, teams, and community, regulatory and administrative decisions that heed the voice and needs of clinicians, emphasis on value on investment rather than return on investment, and research focused on systems-based interventions to ameliorate the problem. As regards the latter issue, Mayo Clinic Proceedings is also privileged to publish in this issue original articles by West et al., Derby et al., and Villendra et al. That exemplify the evolving transition to Well-Being 2.0 proposed by Schanefeld. Such contributions in aggregate reflect the journey of and progress made in this field, and which have taken it from its somber provenance of physician burnout to its current more sanguine stage of physician well-being. This outstanding special article by Schanefeld is a landmark perspective regarding this field and a compelling clarion call for needed system-level strategies and action. Our first highlight article this month uncovers the pathogenesis of acute kidney injury in COVID-19. It is an original article entitled Acute Kidney Injury in Severe COVID-19 Has Similarities to Sepsis-Associated Kidney Injury, a multi-omics study. It is authored by Dr. Miriam Alexander from Mayo Clinic in Rochester, Minnesota, and colleagues from multiple institutions. Among the major complications of COVID-19 is acute kidney injury, AKI, the latter occurring in more than 50% of COVID-19 patients in the intensive care unit, many of whom may require renal replacement therapy. AKI is also a major determinant of outcomes in COVID-19, as it increases the duration of hospitalization, morbidity, mortality, and healthcare costs. The mechanisms implicated in AKI include the following: hemodynamic instability, volume depletion, systemic inflammatory responses, myocardial dysfunction and its adverse renal effects, thrombotic microangiopathy, and rhabdomyolysis. Additionally, the causative virus SARS-CoV-2 can infect the kidney, as the kidney richly expresses the receptor ACE2 that mediates the cellular entry of SARS-CoV-2. Such cell injury enables viral-induced cell injury and cell death in the kidney and the instigation of local inflammatory cascades. The seminal study by Alexander et al. Examined the nature of AKI in COVID-19, specifically questioning the extent to which such AKI resembles sepsis-associated AKI. This renal autopsy study included histopathologic studies and genomic and proteomic analyses. Based on the presence of apoptosis, microvascular changes, macrophage-enriched inflammatory infiltrates, and interstitial CD3, CD4 positive T cells congregating around antigen-presenting cells, the authors conclude that AKI in COVID-19 is similar to sepsis-associated AKI, a conclusion supported by omic data. Specifically, in AKI occurring in COVID-19 and in sepsis-associated AKI, transcriptomic analyses showed an enrichment of genes involved in apoptosis, autophagy, major histocompatibility complex class 1 and 2, and type 1 T helper cell differentiation. Proteomic analyses showed an enrichment of proteins involved in necroptosis and sirtuin pathways. Ultrastructural mitochondrial damage is known to occur in sepsis-associated AKI, a finding the present study also demonstrates, along with the downregulation of proteins related to oxidative phosphorylation. This study by Alexander et al. Is significant and timely from several perspectives that include the following. First, it shows how autopsy studies may be undertaken so as to capitalize on the innovative techniques and accordingly derive novel insights as afforded by multi-omics approach. Second, it attests to the fundamental role of inflammation as a major pathway by which organ injury occurs in COVID-19 in general and in the kidney in particular. Third, as SARS-CoV-2 was not detected in the kidneys analyzed in the present study, these observations underscore the fact that viral tropism of the kidney is not essential for the occurrence of AKI in COVID-19. Fourth, this study uncovers the occurrence of prominent mitochondrial damage and impaired oxidative phosphorylation, thereby highlighting mitochondrial impairment in the pathogenesis of AKI and COVID-19. Indeed, this concept now broadly permeates current perspectives regarding the pathogenesis of AKI in general. And fifth, this article outlines new diagnostic and therapeutic strategies for AKI occurring in COVID-19. The COVID-19 pandemic brought a new disease with many distinct pathogenetic pathways in the causation of organ and tissue injury. However, at least for the kidney, as shown by Alexander et al., the pathogenesis of AKI and COVID-19 bears remarkable resemblance to the pathogenesis of a disease recognized for so long in nephrology and in the ICU, namely sepsis-associated AKI. Our second highlight this month is entitled Artificial Intelligence Augmented Electrocardiogram Detection of Left Ventricular Systolic Dysfunction in the General Population. It is authored by Dr. Anthony Kashu and colleagues from Mayo Clinic in Rochester, Minnesota. Asymptomatic left ventricular systolic dysfunction, abbreviated as LVSD, predisposes to overt heart failure and attendant morbidity and mortality, complications that may be mitigated by the institution of appropriate therapy. The study of Kashu et al. Assessed whether an artificial intelligence, AI, augmented ECG algorithm may predict current and future LVSD. The basis for their community-based study is twofold. First, the authors point out that a relatively simple, non-invasive method for the detection of asymptomatic LVSD would add significantly in detecting patients in the community at risk for ensuing cardiovascular morbidity and mortality. Second, prior seminal retrospective studies by Attia et al. From Mayo Clinic, published in 2019, developed and validated an AI-enabled ECG approach to identify asymptomatic LVSD. Using a randomly selected sample of individuals participating in the Rochester Epidemiology Project, ECGs and electrocardiograms were performed as a study protocol and not because of any clinical indication. LVSD surveillance was undertaken for 10 years after enrollment, the latter conducted between 1997 and 2000. Preclinical LVSD was defined by an ejection fraction less than 40% and without a diagnosis of heart failure. The findings of Kashu et al. Demonstrate that AI-augmented ECG detected LVSD both in the total population and in a high-risk group with high sensitivity and specificity, and that over a 10-year period, incidence rates of LVSD were approximately 10% for those with a positive AI-augmented ECG, compared with 5% for those with a negative AI ECG. These findings, as the authors discuss, provide a basis for multi-center prospective studies on community-based populations that assess the rigor, reproducibility, and cost-effectiveness of this non-invasive screening approach in detecting asymptomatic LVSD. The fundamental AI approach applied to the ECG in both the study by Kashu et al. And the earlier study by Attia et al. Is that of convolutional neural network. Convolutional neural network was introduced in the 1980s, some 100 years after that of the ECG. These two papers on AI-enabled ECG provide a remarkable example of how more recent innovation in medicine may reach back and may be applied to the 100-year-older ECG thereby enabling this time-honored, non-invasive, and relatively inexpensive tool to predict a disease in ways never previously imagined. You can access these highlights and editor's choice articles free of charge during the entire month of October. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the home page and at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on our homepage as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who've made a strong impact in their field of study. You will see many news stories at our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content such as our Path to Patient Image Quiz, medical images, stamp vignettes on medical science, and Art at Mayo Clinic features, as well as articles published online. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.